Hello, everyone. Welcome to Visions 2020. You have joined the Usher Syndrome session. As a reminder, this session will primarily be a question and answer format. The session will last approximately 75 minutes. We'd like to encourage you to be social with us. Share your experiences using the conference hashtag. Pound Visions 2020 on Facebook and Twitter. My name is Joan Fisher. I'll be your moderator. I work for the Foundation Fighting Blindness with the science team. I work primarily with the My Retina Tracker registry and the My Retina Tracker genetic testing program. For this session, you can ask questions by accessing the Q&A feature on the Zoom control bar to type in your question. Some logistical details. Today's session is being recorded and available in closed captioning. To activate the closed captioning, please select closed captioning at the bottom of the interface and select subtitles. If you are using a screen reader, please be aware the controls are at the bottom of the Zoom interface. This control bar may collapse when not in use. If you prefer to prevent the controls from auto-hiding, go to the settings within the Zoom platform. Select Accessibility, and then select Always Show Meeting Controls. The speakers for this session are Doctors Jacque Duncan and Dr. Benjamin Bakall. Dr. Duncan is Professor of Clinical Ophthalmology, Beckman Vision Center, University of California, San Francisco. She graduated with distinction and honors from Stanford University. She completed medical school, internship, and ophthalmology residency at the University of California, San Francisco. Dr. Duncan completed a medical retina fellowship at the University of Pennsylvania, working with Dr. Samuel G. Jacobson and Stuart Fine. Her fellowship training focused on patients with inherited retinal degenerations and age-related macular degeneration. She joined the ophthalmology faculty at UCSF in 2000. Dr. Duncan has expertise in the diagnosis and management of patients with retinal degenerations, including age-related macular degeneration, retinitis pigmentosa, cone rod dystrophy, and Stargardt disease. She has a strong interest in developing imaging and monitoring technologies to better evaluate both the progress of disease and the efficacy of emergent therapies. In her clinical research, she has studied cone photoreceptors in the eyes of patients with many different types of inherited retinal degeneration. Dr. Duncan has served as chair of the Foundation Scientific Advisory Board. Dr. Bakall is a retinal specialist in Phoenix, Arizona, and a clinical assistant professor at University of Arizona, College of Medicine, Phoenix. Dr. Bakall is diagnosing, treating, and providing genetic counseling to patients with inherited retinal diseases. He completed his medical degree at Uppsala University in Sweden, and his PhD at Uppsala University was focused on identifying and analyzing the gene causing Best disease. He continued his laboratory research on Best disease at University of Arizona as a postdoctoral fellow, where he also did his ophthalmology residency training. He completed a medical retina and inherited retinal disease fellowship at University of Iowa, funded by the Foundation Fighting Blindness Allen Ladies Career Development Award. Dr. Bakall is involved in multiple clinical trials for retinal diseases and is a consultant for several projects involving gene therapy for inherited retinal diseases. Dr. Duncan and Dr. Bakall would you like to add anything before we begin with questions?
I would just like to say welcome to the Virtual Visions Community 2020. It's really a pleasure to be with all of you virtually today. In addition to the things that Joan mentioned, specific to Usher syndrome, I'm privileged to be a member of the Executive Committee of the Foundation Fighting Blindness Consortium, which is a group of clinics around the world that are dedicated to studying retinal degenerations. We are conducting a natural history study in patients with Usher syndrome type 2A caused by mutations in the USH2A gene. This also includes patients who have retinitis pigmentosa without Usher syndrome, but the majority of patients in the study have Usher syndrome. So that's a very exciting 4-year study that we're about halfway into, and I'm happy to talk about that during today's session if people have questions about it.
Thank you. Dr. Bakall?
I'm happy to be here online this year. I think we're supposed to be in Minnesota, but at least I can supply the Swedish accent.
Okay, we will now take questions. As a reminder, you can ask a question by accessing the Q&A feature on the Zoom control bar to type in your question. To ensure we get to as many people as possible, we will limit 1 question per person. I'm accessing the questions.
Looks like someone has a question about Usher syndrome type 3A.
That's correct. What new research is being done on Usher 3A?
And do you want to take that, or would you like me to start?
I can start a bit and you can fill in. So
Sure.
Usher syndrome type 3. So just kind of, so for people that don't know about the different forms of Usher syndrome, type 1 is the one with profound congenital hearing loss, early onset retinitis pigmentosa, and severely decreased balance. And Usher syndrome type 2, which is the most common variant, is retinitis pigmentosa, in most cases diagnosed in the teens or so. There's early onset mild to moderate hearing loss that's not progressive and typically normal balance. And Usher syndrome type 3, which this question is about, is retinitis pigmentosa, can be variable onset in the teens most of the times, a little bit later sometimes. It can be progressive hearing loss, and typically the balance is pretty good. There's one report regarding, or there's some reports regarding atypical forms of Usher syndrome. Some people call it Usher syndrome type 4, but that's not really determined. So regarding this Usher syndrome type 3, it's called the CLARN1 gene is the gene causing that. So there's a lot of research on that specific gene. There are different mouse models. They've been doing gene therapy using adeno-associated viral vectors for those mouse models. They showed regarding the hearing, they can improve the hearing if those animals, the mice are treated before day 10 or so. So there's definitely trials going on for Usher syndrome type 3. There are no active human clinical trials yet, but that's most likely going to happen. I don't know if you have anything to add, Jackie, but I don't know about any active human trials right now.
That was a really nice summary of the different types of Usher syndrome. Thank you so much, Ben. It's true that a lot of work is being done to develop treatments in Usher syndrome type 3A. One challenge has been that the mouse model, I think, doesn't develop retinal degeneration to a significant extent. So having an animal model really helps to advance therapies, but certainly lots of therapies can be developed in cell cultures. And importantly, people are starting to, we are working with members of the USH3A community should plan a natural history study so that that we're discussing that as a future natural history study for the consortium, so that we can learn how patients with Usher syndrome type 3A change over time, such that when a treatment is investigated, we can compare it to what would have happened in the absence of a treatment. And that's where I think the consortium plays an important role in providing natural history study data that can then support development of therapeutic trials.
Thank you. We have another question. What therapies are available for CME, secondary to RP, in Usher syndrome type 1?
I can start with that one. So CME is short for cystic macular edema. So how the retina works, the retina, as many of you, is kind of like the wallpaper for the inside of the eye. And then the very center of the retina with the sharpest vision is called the macula. So if you have swelling or edema in the center of the retina, that's called cystic macular edema. And many people with retinitis pigmentosa, that where the peripheral vision is decreased, typically the central vision is what people rely on. And if you have edema, cystic macular edema in the center, then the central vision starts to be affected. So we know that there are several different treatment options for cystic macular edema for people with retinitis pigmentosa. We usually start with carbonic anhydrase inhibitors. So you can apply that as a topical treatment with an eye drop a few times per day and see if that helps to dry out the center of the retina and improve the vision. If the topical treatment doesn't work, oftentimes we switch over to an oral medication, acetazolamide or alternatively metazolamide, to see if that helps. So these carbonic anhydrase inhibitors are sulfa based. Some people that are sulfa, sensitive sulfa can't use that treatment modality. If some people have a very strong inflammatory component, we may even have to use steroids in different forms, either as drops, prednisolone or Durezol is one drop that can be used. You can even do intravitreal injections, either with the Camelog or similar medication, or even long-term implants have been tried to decrease the swelling. So there are depends on how much edema the person has and how they respond to different treatments. But there have been also other different clinical trials. See I think there are suggestions to start up clinical trials regarding what are the best treatment modalities, run by the Foundation Fighting Blindness for different forms of retinitis pigmentosa. I think that's right, Jacque. Is that right? We're planning to start that? Yeah.
Great. That's great, Ben. Thank you for that. Yeah, the consortium has constituted a working group under the guidance of Dr. Byron Lamb at Bascom Palmer University of Miami Medical School. And together, we're trying to discuss the different types of treatments that have been tried with cystoid macular edema in Usher syndrome type 1, as well as other retinal degenerations. It is a very visually devastating complication that can really affect people's ability to see, read letters, and recognize faces. So we recognize it's a very important problem that affects up to 1/3 of patients. But our understanding of why it develops is not entirely clear. Some people think that inflammation plays a major role, which is where things like steroids may be important as therapeutic agents, whereas other people think it's a response to degeneration that is non-inflammatory and may respond better to different types of therapies. So together with the other members of the working group, we are trying to use our collective experience to best understand whether there are many different kinds of macular edema that might respond differently to different kinds of treatments, and design a study that would help us better understand how macular edema occurs and what might be the best approaches to treat it. As Dr. Bakall said, carbonic anhydrase inhibitors are often the first line of therapy. Initially, people will often try a drop because that often will work for many people. but it doesn't work for everyone. And there's many forms of macular edema that have to do with scar tissue on the surface of the retina, and that doesn't really respond as well to any of the treatments we have. So we're working hard as members of the consortium to try and better understand this problem and hopefully identify more effective therapies.
Thank you. It looks like we have a pause in the question queue. So attendees, if you have a question that you've been holding back on, this is the moment. This is your moment. Dr. Bakall and Dr. Duncan, I know in my limited experience in working with people in the registry, there's a lot of confusion about the genes that identify as Usher genes, but are primarily not hearing and vision loss. Can you talk about that a little bit for people who have RP and get a Usher gene identification?
I'd be happy to start and then have Ben chime in as well. It's true that a number of genes that cause Usher syndrome also can cause retinal degeneration with no effect on the hearing at all, in the absence of any hearing. USH2A is probably the most common cause of both Usher syndrome type 2, as well as retinitis pigmentosa inherited in an autosomal recessive manner. So that's a good example and we're not entirely sure why some mutations cause hearing loss and RP and others, other kinds of genes just cause Usher syndrome or just cause RP, but many that cause Usher syndrome also can cause RP with normal hearing. We, again, back to the consortium, through the RUSH2A study, we're working with an outstanding geneticist named Rob Hufnagel, Hufnagel, who is at the National Eye Institute, and he's been looking at the genetic mutations of all the participants in the RUSH2A study. He's writing a paper about it right now. One thing that this study has found, as have other studies, when patients have a particular kind of mutation that stops production of the protein completely, it's called the truncating mutation. They have 2 copies of truncating mutations, which are maybe have a more severe impact on the protein. They're more likely to have Usher syndrome, whereas ones that just cause a misspelling in the gene are more likely to cause retinitis pigmentosa. But that information is being analyzed and will be presented as a publication in the very near future.
Thank you.
Yeah, regarding if you have hearing loss or not, so it's quite variable. There are even reports where siblings who have the same 2 variants, some have normal hearing and some have decreased hearing. So there may be that some individuals, even though the variants are identical, have other protective factors, so that the remaining genes and proteins are protecting, causing normal hearing in some individuals. So there are still a lot of things that we don't know. So that's really an important area to research why some people are affected, having the hearing affected as well.
Thank you. We do have a couple more questions from the attendees. Question is, I also have 3A. Would optogenetics, which they are doing a trial in Long Island, stem cell transfer help 3A? Or is there a different clinical trial that would benefit someone with advanced vision loss, seeing light and colors?
Do you want to start with that, Ben, or you want me to take it?
Well, so I understand what they're doing in Long Island. I think they're collaborating with AGTC. Is that right? They're doing it's a gene therapy trial where they add photopigment. So I think initially what they're doing, it's kind of similar to what Retrosense Allergan is doing, but they go one step further. So let's say you have very advanced retinitis pigmentosa. You do by gene therapy, you're making the remaining cells in the retina the light detecting cells. But that vision is not perfect. So So I know initially for the retrosense trial, I can have to extrapolate. They're treating patients with very poor vision initially, hand motions, light perception, and they're with the hope that they can see outlines of things, maybe see large letters, come to that level. I think that the step further that they're doing in Long Island is they first do gene therapy, but then in addition, the people are wearing a device, looks like sunglasses, but which is a camera that then stimulates the retina in certain ways using probably patterns and frequencies of light to stimulate the cells that have been treated with gene therapy so they may be able to see better compared to other competing approaches. So that's very hopeful, mainly for people who have very advanced vision loss from retinitis pigmentosa. So there are definitely different approaches. Depends on how. That's the challenge with, and Jacque can talk about that as well. So what kind of treatment should be applied to a person depends on where they are in the disease process. So kind of generalized, if a person has early onset retinitis pigmentosa with a lot of remaining cells starting to have decreased night vision, maybe decreased peripheral vision, you will not apply treatments that prevent loss of those cells. So gene therapy is typically good specifically for that gene. If you have lost more of the vision, so let's say you're more advanced stage, then there are other approaches like replacing the cells or doing gene therapy where you make the remaining cells light depicting. So there are other approaches as well. You can use something, not just adding a normal gene, but you can use something called allele-specific oligonucleotides. That's been shown to work, especially in animal models for Usher syndrome type 1C, both for the hearing and for the retina. So those are little snippets of DNA or RNA that's added and that makes the gene machine read the gene as normal. And that's also treatment that can be done early on in the disease process. Have there are several different other disease treatment strategies that can be applied in different terms of the disease.
Right, and just to continue from there, just briefly, for people with more advanced vision loss, if you lost a lot of your photoreceptors, there are very few cells remaining to receive the gene therapy or to respond to the antisense oligonucleotides kinds of therapies. And so as the questioner was expressing, optogenetics is a potential way of stimulating cells that aren't photoreceptors to respond to light. Another option for people with very advanced vision loss might be stem cell therapies. There are some stem cell therapies that are being developed as to release neurotrophic factors that would intend to keep cells from dying for patients with earlier stages of disease. But there is hope that sometime there might be the opportunity for stem cells to revitalize or potentially even someday replace photoreceptors that have degenerated. It would require them to make meaningful connections to the cells that have not gone away, such that the brain could perceive the light. So that's another potential avenue. And then finally, prosthetics like the Argus 2 chip and Pixium chip would use electrical impulses to stimulate the inner retinal cells that remain after the photoreceptors have all gone for people with very advanced vision loss. So optogenetics, stem cells, and prosthetics would be the kinds of therapies that might be appropriate for people with very advanced vision loss, whether that be Usher, due to Usher syndrome type 3A or other types of retinal degenerations.
And then there's another very interesting research area, which is CRISPR-Cas9. So where you can kind of, by molecular engineering, you can correct the spelling error or the mutation in the gene, either in a cell culture or may also be done in vivo, so in a living person. But that's we don't know how that's going to work and what the efficiency of that treatment is. But that's a very exciting treatment strategy as well.
Also appropriate for people with remaining photoreceptors. So that's like gene therapy and antisense oligonucleotides. That's for people who still have photoreceptors to treat.
Thank you. Dr. Bakall, you faded a little bit on the end of your last answer. I could still hear you, but just let you know that, yeah, you might need to get a little closer to the mic. Okay. Our next question. My daughter has developed cataracts that a retinal specialist says needs to be removed. Should these be removed by a retinal specialist, or can it be a cataract surgery?
I can start with that. So I think it's better if a cataract surgeon is doing cataract surgery. But the question is the cataract affecting the vision enough to need cataract surgery? That's a very difficult question that I study with a lot of patients with retinitis pigmentosa. So many patients with retinitis pigmentosa, both with Usher syndrome and other genes, they develop a little small haze on the back part of the lens in the center, small posterior subcapsular cataract. Oftentimes, initially, it really doesn't affect the vision very much. So they can be watched. One other problem with doing, there are a few other problems with doing cataract surgery early, especially in young people. So people younger than 40 or so, they can accommodate. So they, if they have correct glasses, they can both look at far and at near effortlessly. However, after age 40, 45 or so, it's called presbyopia, you start needing reading glasses. So if you do cataract surgery on a younger person, they will lose that ability to move back and forth. So they basically become like a person that's 45 or older. And that can be frustrating for some young people. So that has to be taken into account as well. Some people with retinitis pigmentosa are very light sensitive. So in some cases, if you do cataract surgery, you get more light in the eye. And I've seen some people with RP wishing they didn't have the cataract surgery because they became so light sensitive. So it became really hard just to read a plain piece of white paper with black text. So that's why it depends on what the age is, how dense the cataract is. Just because there's a cataract doesn't mean that it has to be removed. So it's good to get a second opinion, oftentimes by someone that has seen several people with retinitis pigmentosa, and kind of have those thoughts in mind with loss of accommodation and increased light sensitivity.
Yeah, whenever we recommend or consider whether a cataract should be removed in a patient with Usher syndrome or retinitis pigmentosa, we have to always weigh the risks and the benefits. And I agree that lots of patients have very small cataracts that don't need to be removed, but it's true that at some point, sometimes the cataracts will progress over a period of months or even years to the point that they really are making it more difficult for patients to see fine details and can cause a lot of symptoms of glare. If the retina underneath the cataract doesn't show cystoid macular edema, like we talked about earlier, or evidence of retinal thinning that would suggest the patient is not likely to benefit from cataract surgery, oftentimes we do recommend that a cataract surgeon take out the cataract, and we usually recommend that the best cataract surgeon we know do that surgery because we want it to be done with very little light exposure and to be done in the shortest amount of time possible to reduce the risk of possible problems like damage to the sensitive remaining retinal cells or making cystoid macular edema, retinal swelling worse. Oftentimes we recommend extra steroid treatment before and after the surgery in patients with retinal degenerations to try and prevent problems like retinal swelling. But many times cataract surgery can really be helpful for people if their cataracts have progressed over a short period of time. And I think in consultation with the retinal specialist, I think the cataract surgeon is the very best person to do that surgery. I wouldn't want a retinal surgeon doing that work. I would like the very best, most high volume, extremely experienced cataract surgeon around to do that surgery.
Yeah, I agree. I think a retinal surgeon should do cataract surgery only if there are complications So it's better to have a cataract surgery if there haven't been any other surgeries in the past or there were no other problems. Yeah, you definitely want to have someone that has done cataract surgery and retinitis pigmentosa patient before doing it. We know that from published studies, there is a bit higher risk of complications during cataract surgery as a baseline in patients with retinitis pigmentosa. But if the cataract surgeon is aware of the risks, they can take precautions and do a really good job. So I've seen a lot of patients with retinitis pigmentosa are very happy after cataract surgery.
Great, thank you. We have another question. Since Usher syndrome type 1 is so rare, will transference from FDA-approved treatment for more common retinal disease such as AMD be possible or probable?
I'll try and take a stab at that one. It's always possible for a doctor to use a treatment that has been approved by the FDA for one indication in an off-label way for something else. The challenge with retinal degenerations is they are very rare, and they're very different from things like age-related macular degeneration. They really are mystically very different. They're oftentimes different one from another. There's 300 different genes that can cause retinal degenerations, and although we talk about them all together, they likely are 300 slightly different diseases. So I think one of the things that has been very exciting in the field of retinal degenerations is that people have, industries and different entities, sponsors, have developed a lot of interest in developing treatments for these diseases because the FDA gives them special consideration. They can give it fast track designation for orphan disease medication development. So since there is now an FDA approved treatment for patients with RPE65 related retinal degeneration, a lot of companies and a lot of investigators have developed a lot of interest in developing therapies specifically for retinal degenerations, which has made this a very exciting time in the field. It's true that Usher syndrome is quite rare. There has been underway a gene therapy trial for Usher syndrome type 1B for a long time. That's been challenging because that gene is very large, and so it doesn't fit into the same carrier or vector, viral vector, that was successfully used to treat RPE65 related retinal degeneration. So different strategies are being investigated to treat USH1B. Similarly, Usher syndrome type 2A is also caused by a very large gene. USH2A mutations cause Usher syndrome type 2A, and that is also too large to fit into the kind of packaging device that was used to deliver RPE65. So those diseases are a little more challenging, and that's why people are trying different approaches like Ben was describing with antisense oligonucleotides or CRISPR-Cas9. But as far as I know, most of those types of trials are gene specific. They're really trying to develop a treatment that is specifically designed to help people with a gene specific mutation. And in some cases, they're actually mutation specific, where some of the antisense oligonucleotide trials are specifically designed for people with a particular mutation in the USH2A gene. Similarly, CRISPR-Cas9 therapies would also be specific. So it's possible that there could be an FDA-approved treatment for something that could be transferable to Usher syndrome type 1, but I think it's more likely that treatment might be more specifically developed just for an Usher syndrome type 1 gene, given the amount of interest in the field and given the success that has been achieved to date with gene-specific therapy for RPE65. Clearly, Usher syndrome is not the same as RPE65, and there's lots of different challenges associated with that. But I know I can assure you or give you hopefully some optimism that there's definitely a lot of research underway to try and develop gene-specific treatments for people with Usher syndrome as well.
Yeah, if I would think, if there would be any benefit directly from AMD, it's hard to find specific examples. One thing I could imagine is that especially as the field of stem cell-based replacement therapy evolves, since macular degeneration is much more common disease. If that seems to be working, replacing patches of loss of cells in macular degeneration, then that can be used more broadly in other diseases as well. Especially if you can recreate the retina in several different layers, kind of like a sandwich. You have the supporting layers, you have the photoreceptors overlying that, maybe even the vascular layer underneath. If that can be inserted as a sheath and improve the vision in, for example, age-related macular degeneration, then the next step probably would be macular dystrophies like Stargardt disease, but then in the extension, that can also be used for patients with retinitis pigmentosa. So that's, I would say that would be a benefit that would be drawn directly from AMD. But otherwise, it's very different diseases, especially genetic-wise.
Yeah, the only other thing I can think of that might have cross-disease appeal would be non-gene specific kinds of therapies like neurotrophic factors or antioxidant kinds of therapies that are being investigated, which may have benefit in keeping photoreceptors alive regardless of the genetic cause. And those studies are ongoing to determine if those are going to be effective. I predict that, like Ben said, they probably would be more likely to be treatments developed for retinitis pigmentosa that would be beneficial for Usher syndrome patients, perhaps more than AMD, but maybe something could be developed for AMD that would have some benefit. It's hard to know. Like stem cells are a great example.
Yeah, going off a little bit of a tangent, not directly to AMD, but you mentioned the nutritional or the agents that can be taken. The Nacuity company, they have this N-acetylcysteine compound, and Johns Hopkins, they are going to start a clinical trial soon. When I looked up yesterday on the website, they say they're looking for 48 subjects to treat patients with retinitis pigmentosa to prevent progression. They haven't started recruiting yet, but if you live at the Johns Hopkins area, you may want to contact them and see if you're interested in participating. But that's going to be on their website. Also, clinicaltrials.gov is a good website to see. You get contact information regarding the trial like that.
Thank you both. So we have a break in the question queue. So if anyone else has any questions that they'd like to submit through the question and answer icon at the bottom of your screen, please do so. In the meantime, we're going to try to take unmute some people who have their hands up and take some questions that way.
Good morning, Martha Steele. You're available to talk if you want to unmute yourself.
Alert, audio now unmuted. Zoom webinar. Can you hear me? This is Martha Steele.
Yes, we can hear you.
Okay, thank you. I have Usher 2A. I have a question about another potential therapeutic approach that I don't really know anything about, but I wondered if you could comment on it. As I understand it, it has something to do with some animal models, perhaps the zebrafish being one, where the retina itself is able to regenerate its own lost photoreceptor cells through, I believe, some sort of activation of a protein. I don't really know much about it, and I'm sorry I'm not giving very good detail, but it sounded like there are some animals that are able to regenerate retinal cells, and there may be some research to try to determine that mechanism and whether there is any potential mechanism that might be activated in the human retina to regenerate lost photoreceptor cells.
I can start a bit briefly and you can fill in, Jackie. So humans are not animals or fish especially, so that's a big challenge. So you're completely correct. Zebrafish and some other animals, they can regenerate the photoreceptor cells. So humans don't have that ability, unfortunately. We find that So it's great to use different animal models. So zebrafish is a great model. In eye research, we use a lot of mice, but one of the problems with some mice, especially if you study the center of the vision, is that mice don't have a macula, so they don't have that center sharp vision like humans do. So yeah, apes and monkeys, they have that. And humans can't regenerate the photoreceptor. So that's why when we talk about stem cell replacement therapy, we're talking about generating photoreceptor in the lab as a sheath or in a suspension, and then inserting that in a safe fashion underneath the retina without causing complications or vision loss. So it's definitely a challenge. So, but there's a lot of good research that's been done on zebrafish and other animal models, identifying the genes, understanding how genes and the proteins they code for work and how they interact. Even some forms of retinitis pigmentosa have been identified thanks to identification of genes in different animal models. So it's definitely a very important field to work on different models to learn more that then can be applied to humans.
And you're right. I think people are really interested in trying to figure out why that is, why teleosts like zebrafish can regenerate retinal cells after, in response to injury and after a mutation causes them to die. There are a number of animal models in development. With funding from Foundation Fighting Blindness, we have a program project award in which we're collaborating with investigators at Medical College of Wisconsin and UCLA to try and develop models. Some are cell-based models with collaboration at UCLA, and others are using animals like 13-lined ground squirrels to try and be a little bit more like people, but also in that they have lots of cones in the retina, unlike mice. And they have a sort of different photoreceptor structure than mice, because the mouse models, as I was saying, of Usher syndrome often don't develop retinal degeneration. So that has hampered our ability to understand the mechanism of degeneration in patients with Usher syndrome. The foundation is also has recently put out a request for applications to develop large animal models of different forms of Usher syndrome and other retinal degenerations, and information about that and the awardees of that program will be announced in the very near future. So the foundation is committed to trying to develop new models to get to just the point of your question, why is it that some species can regenerate their photoreceptors and why can't people do it? It would be terrific if we could use that same kind of a method to replace photoreceptors that have gone away in people. And it would also be great if we had animal models to better understand the mechanisms and to try out experimental therapies. So those are both areas of active research that the foundation is supporting.
Great, thank you. We do have some more questions in the question queue. Besides the registry, what other ways can an Usher syndrome RP person access information about clinical trials?
I think one of the Foundation Fighting Blindness has a great website, and also you can subscribe to the newsletter to get updates. That's really an unparalleled source of information for a layperson. You even get the information faster than some of the scientists because the updates are coming frequently, even faster than the media. If you want to look up specific clinical trials, I think clinicaltrials.gov is it's kind of a busy database, but at least if you search from a specific gene, it's sometimes hard to navigate because you don't know if the trial is appropriate for you or not. And some of, just the caveat is that some of those trials are not something I would recommend anyone participating in, but most trials are, and some of them in different countries. So it's good to ask a retina specialist, especially. It's good also to see your local inherited retinal disease specialist. That's good to have someone, even though you don't have one in your city, there are national centers. So those specialists are updated on what may be appropriate for your specific treatment. There are a lot of support groups on Facebook and similar, but I can't say that there are any other great sources. And contacting your local university. Sometimes they have really exciting research projects going on and support local research for the different universities. Those are kind of good avenues to help advocate and yeah, support research and retinal dystrophies in general.
And I think Joan can correct me if I'm wrong, but the foundation also supports, used to have a thing called the Partners in Retinal Health, where they would have a list of providers around the country that had expertise in retinal degenerations. And I agree with Dr. Bakall that it's very critical for you to discuss any potential therapy with a person who knows you, who's seen your eyes and is taking care of you. So making sure that you have access to inherited retinal degenerations or retinal specialist that knows your eyes and can give you good advice about whether treatment might be appropriate for you or not is really absolutely critical. In addition to the registry and the newsletter, I think I want to also just commend the Foundation Fighting Blindness for putting on programs like Visions every other year and local programs in your community, like days, they have Save Sight Saturday, or so they have different events on a regular basis where experts that are usually local will come in and talk about the research that they're doing, research that's going on in the field, and trials that might be developing, which you might be interested in learning more about.
Thank you.
Yeah. I would just be careful. There are a lot of scams. I see people come in and they also contact me all the time regarding to hear about different treatments. I live close to the borders in Mexico. There are some doctors that state that they can treat retinitis pigmentosa. There's one place in Cuba. I saw one lady having lost vision in the eye they treated. So there are some other places where they inject cells behind the eye. I don't really know how that would affect the vision at all. So, but all I would say one thing: if you're interested in any kind of clinical trial, you shouldn't have to pay any amount of money to be part of the trial. So if they require $10,000, $20,000 to have any kind of experimental treatment, it's most often it's a scam. It doesn't work. So all clinical trials that Foundation Fighting Blindness sponsors and other serious trials, they usually have a sponsor, which is typically a company or university that pay for all the expenses, even transportation. So those are done in a rigorous fashion to ensure that they're safe. Because any treatment, we really don't want people to lose their vision. That's really number one. And we talked about using cells that can replicate, like for example from zebrafish. We don't want cells to start replicating inside the eye, basically form a tumor, so uncontrolled cell growth. The good thing about the eye is you can see what's going on. You may be able to treat cells that are growing with laser or other treatments to stop the growth, but you don't want to cause problems like membrane, scar tissue, retinal detachment. We've seen those complications in people that have undergone non-serious stem cell-like based treatment trials or treatments.
Yeah, that's a really good rule of thumb. If you are being asked to pay a lot of money to be given access to a treatment that is an experimental treatment, then sort of I would avoid that treatment because it should really, if it's, and the other thing to remember is a clinical trial is exactly that. It is a trial. It is not a proven therapy. And therefore you shouldn't have to pay out of pocket for it. And it isn't clear that it's going to help. It's being investigated to determine whether it's going to be safe and helpful. So before you decide whether or not to participate in a clinical trial, it's important to really understand what's involved with the trial, what's being asked of you, what the likelihood of benefit or risk to you would be. And it's important to have that conversation, not only with the investigators, but also to talk with somebody who knows your eyes, someone who's a retinal specialist that can give you advice about whether it would be a good idea for you to consider participating in a study. No matter what you do, if you participate in a trial, you will help us advance the field and help us understand how different treatments might or might not be helpful, but it may not be helpful to the person who participates in the trial. And so that's a real important thing to remember about trials. They're not treatments. They're experimental studies to help us understand whether a treatment is safe and helpful.
Great, thank you. We have another question. Why do two people with the same genetic Usher mutation progress differently?
$1 question right there. Go ahead.
Yeah, we touched base on that one, early on regarding, we even see that you mentioned before that two people, siblings, for example, that have the exact same variants causing Usher syndrome. Some have just retinitis pigmentosa, the other one has Usher syndrome with hearing loss, and some progress more rapidly. It could be several different factors. That's something that's really interesting to study. Are there other protective factors, other genes that cause that? Some people develop cystic macular edema. Yeah, I can't say that we have the answer for that right now.
Well, I agree. I don't have the answer to that either, but it is a valuable question. And I'll tell you some things that might impact how different mutations within the same gene affect disease severity. And then the question really that's interesting is why the very same gene and the very same mutation in members of the very same family can sometimes have very different effects. So it's true that different kinds of mutations may have different effects on the expression of protein. And so therefore certain kinds of mutations might have a more severe effect on whether or not the protein is produced, and therefore might have more severe effects on the cell survival. So that's one category of difference, is that the severity of the mutation might be different between different people. But even in people who have the very same genetic mutation, different factors can influence the severity of the disease. And some of those factors might be genetic mutations that aren't in that gene, but are in other genes. Those are called modifier genes, where we don't have a clear understanding of this, and it's very hard to study, but where different genes elsewhere in the person's DNA influence the way a second gene like Usher 2A or whatever Usher syndrome gene is responsible for your degeneration affect the photoreceptor cell survival. Other things that may play a role may be environmental, like smoking, exposure to antioxidants, exposure to lots of light may influence the rate of progression. It's some people think that things like even exercise or stress or having a baby, being pregnant, may influence the rate of progression. And these types of things are very hard to study in a careful manner because these diseases are very rare. So I have to say that's an extremely good question, and I wish I had a better answer for it, but it's one that lots of people are interested in studying.
Thank you. Next question is, if you participate in a trial, are you ruled out for participation in a different research trial?
We can start with that one. You want to start back here?
You want to take that one?
Oh, sure.
Okay, or I'm happy to too.
It just depends on what kind of trial it is and what treatment it is. So let's say it's a natural history trial like the Rush 2A. It's not the treatment. So the short answer is yes, you can participate in the treatment trial. However, if you're part of a treatment trial, it depends on what the treatment is. So let's say it's an oral agent that is washed out of the system a certain time after you stop taking it. If you later want to be part of a gene therapy trial or a stem cell based trial, you will probably be able to participate in that second trial. If you participate in a gene therapy based trial, it may, as of now, many trials exclude you from being part of a trial treating the same eye. Maybe the other eye can be treated with a different gene. It's possible, but the thing is that when you conduct a clinical trial, you want to make sure that the people that are treated, all the subjects, are as equal as possible. So if you have an effect from the treatment, you want to know, is that because of the treatment in the trial? You don't want to have any other factors interfering, like any other gene that's treated. So it depends very much on which trial you're participating in, what stage of the disease you are, what your vision is, which eye that has been treated. So it's there's no short answer to this question. So it just depends on what's going on. So that's always good to, before you enroll in any clinical trial, to have that discussion from the start and ask, will this preclude me from being part of other trials? Before we start any clinical trial.
Yeah, I think that opportunity cost is something you really have to take into consideration before you participate in a clinical trial, because a lot of trials will prevent or include in as part of their exclusion criteria prior participation in any clinical trial that involved gene therapy or cell-based therapy. So it's entirely possible that if you participate in a trial, even one that might be reversible, it might prevent you from being a part of another trial. It would not prevent you necessarily from receiving a therapy once it was approved by the FDA if it had already been shown to be safe and effective. It's entirely possible that you could still get that treatment, but it is maybe even likely that you would not be able to be part of a clinical trial of a second investigational agent if you had been part of a trial that either involved gene therapy or cell-based therapies.
Yeah, there's one person that was part of a gene therapy treatment trial, not for Usher syndrome gene, but it was for RP65 to one eye, and that was a different treatment than Luxturna that was later approved. And then when Luxturna came out, that person received Luxturna treatment in the other eye. So that shows that if it's approved by the FDA, you can receive treatment later on in the other eye. But yeah, in the same eye, that depends on what treatment it is. I would say, let's say you're part of a gene therapy treatment trial in one eye and the vision stays about the same, or maybe it's affected later on. If there's a stem cell based treatment that's approved by the FDA, most likely you'll be able to receive that in the same eye. That's a guess, but that's kind of down the line.
Great, thank you. So we're coming up on 12 o'clock. This session is scheduled to end at 12:15. We have 2 more questions. First question, can you discuss how different Usher syndrome subtypes are developing? For example, a person with advanced RP still having night vision doesn't fit in the existing profile of Usher 1.
So the question is, how do we define the different subtypes, and why are there some patients that seem to be a little bit different than the classic definition? Am I understanding that question correctly?
That's how I read it, yes. It's a person with advanced RP still having night vision, how they don't fit into the existing profile of Usher 1.
Yeah, well, I'm not sure if you've had genetic testing and you know which type of Usher syndrome you have, but despite all that, it's true that Usher syndrome type 1 usually is associated with severe vision loss at night early, and usually the central vision is preserved until late. But as we've been discussing throughout this session, it's true also that there's a lot of variability from person to person. And so it is possible that in your case, there are rods surviving that are allowing you to see at night, despite having lost other forms of vision to end at a stage that is considered advanced. So I think it's just another example of the variability that exists, not only amongst the 6 different genetic forms of Usher syndrome type 1, but even within patients with the same kind of genetic mutation that causes Usher syndrome.
Yeah, and it's hard to know because I think it's a very individual question for that one specific person. But as a rule, in most cases, recognized pigmentocyte starts with decreased night vision. That can be variable. It may not be complete loss of night vision. So you may be able to see, if there's sufficient light, maybe the night vision, it's variable. One other thing that we see with recognized pigmentocyte, you need more contrast, so even during daytime. So having dark background and light or white text is often easier for a lot of people. But yeah, regarding that specific question, it's hard to see what subtype it is. I would recommend genetic testing so you know exactly which gene is causing. So for sure it's Usher syndrome type 1. Some cases, when we do genetic testing, it could be a bit of a challenge in some individuals where we don't always find the 2 variants causing Usher syndrome. Only one variant is identified. And as of now, all forms of Usher syndrome are recessive. That means that both copies of the gene the two copies you inherit, one from your mother and one from your father, both have to be affected for you to develop Usher syndrome. So in some cases, we only find one affected variant, and we assume that there is a second variant that's hard to identify, and then people get the diagnosis, for example, of retinitis pigmentosa caused by the USH2A gene, where only one copy has been identified. So there's a bit of a challenge just kind of with genetics and knowing exactly what. So really what I'm trying to get to is that in some cases, people are diagnosed with Usher syndrome or retinitis pigmentosa and Usher syndrome, but it's not really retinitis pigmentosa. It's more an advanced form of this different disease like Stargardt disease, and those people can have pretty okay night vision, even though it looks like retinitis pigmentosa. So there are some challenges in diagnosing people with different retinal dystrophies.
Great, thank you. So we've come to a break in our questions from the group. However, there was a question the other day in another group, and this might be a good time, an opportunity for you to comment on how some of the work around RP is beneficial to the research behind Usher syndrome.
Yeah, well, I would suggest that a lot of the work revolving around RP or specifically dedicated to RP probably has relevance for Usher syndrome. I think that as we've discussed, a lot of retinitis pigmentosa is caused by genes that cause Usher syndrome, and so therefore it's directly relevant. But also there are just similar patterns where, as we were discussing, rod photoreceptors tend to be affected earliest, followed by photoreceptors, and any kind of therapy that sustains or supports or contributes to the survival of the rod and the cone photoreceptors in a patient with retinitis pigmentosa is likely to be beneficial for a patient with Usher syndrome as well. And that's where these antioxidant kinds of therapies like N-acetylcysteine or N-acetylcysteine amide, which is the compound being developed by Nacuity, might have benefit. Other kinds of neuroprotective kinds of therapies. There are stem cells that are being used to deliver neuroprotective agents, deliver neuroprotective proteins that might be beneficial both for Usher syndrome as well as retinitis pigmentosa, might be beneficial. So I think it's really wonderful to have a group like the Foundation Fighting Blindness that brings all these entities together to support research in both of those fields that might have relevance and applicability for patients with both those types of diseases.
I agree.
Yes.
Certainly the mutation-independent kinds of therapies that are being developed might be relevant for everybody with retinal degeneration. It's important to think about like rod-cone versus cone-rod. And so therefore retinitis pigmentosa probably has more relevance for Usher syndrome than disease that is being conducted for cone-rod dystrophy or maculopathies like Stargardt disease or BEST. But certainly there's a lot of overlap between Usher syndrome and RP.
Thank you. We do have a new question, actually two new questions that came in together. What is the most recent information on what's going on in 1C space? And is optogenetics a possible treatment for 1C in the future?
Yeah, we touched base on optogenetics earlier in the session. So that's, just for people that don't understand what that is that when you lost some of the photoreceptors, you make the remaining cells, typically the ganglion cells and bipolar cells, become light detecting. So you kind of bypass one level of amplification of the signal in the retina. So those bipolar and ganglion cells, they connect to the optic nerve and can send a signal to the brain that you can see light. So that's what optogenetic is. You can either add that by gene therapy, so different competing trials going on right now. Yeah, we mentioned that RetroSense, Allergan has one trial. There's one other trial going on. AGTC has one gene that they basically take photopigment, a gene for photopigment from bacteria or from algae, and you make the remaining cells lipopectin. So that's really exciting. There are also research on kind of photo switches, compounds, maybe more short-acting treatment that's given not just one-time treatment as gene therapy, but you give it more frequently, and you make the remaining cells in the retina lipopectin. So so optogenetics is definitely a very exciting research area. You kind of bypass the photoreceptors and make the remaining cells send a signal to the brain to detect light.
Regarding USH1C, I understand, and I'm not involved in this research, but I think I understand that there's a clinical trial. There's a lot of animal work in USH1C to try and develop these antisense oligonucleotide therapies that Ben was talking about earlier in the call or in this session. And I understand the National Eye Institute has a natural history study of patients with Usher type 1C underway, and I know in the past, at least, if not currently, Jennifer Lentz has been supported for research to develop therapies like gene modifying therapies like we were talking about earlier, antisense oligonucleotide therapies specifically for Usher type 1C. So I'm sure that I know there's a lot of work going on in that area. And that was, we had discussed creating a natural history study for kind of all the Ushers, and we're working towards that goal with a couple of organizations for the consortium. So you may hear more about this in the future. In the process of investigating what was going on in the field, that's where I learned about the Usher 1C work. And so I am not personally involved in it, but I think there is a lot of research being done in USH1C to try and develop therapies and also to do a natural history study, which I think is underway.
Yeah, I would just add that, so Jennifer Lentz in Louisiana. So just looking at those animal models for USH1C when you treat with allele-specific nucleotides is really amazing. Just looking at the data and the videos of looking at those mice, the animals that have been treated early on compared to animals that have not been treated. For example, the treated animals have normal balance, they have normal hearing, and they later on, she's shown on that they do develop retinal dystrophy as well in different ways, and you can kind of treating early on, then you can prevent that degeneration of the retina. So that's really, really exciting. But what it shows, some of those experiments shows that you have to treat really early on with gene corrective therapies, and that's a challenge when you've already developed disease in a certain stage. So then, specifically for USH1C, but it's applicable to other treatments of Usher syndrome, is that it's the same treatments we've been talking about later on. It's stem cell based treatments. Yeah, all depends on where you are in your condition.
Great, thank you. It's 12:09. It looks like we have time for one more question, and that question is from a telephone caller. So Martha, if you want to unmute and ask your question.
Okay, this might be, I'm sort of thinking of a question to kind of go big picture a little bit. I would be interested in your comments about why or if you feel more or less optimistic today versus, say, 5 years ago about potential treatments for vision loss associated with Usher syndrome, and what approaches you generally feel are most promising based on what you know today. And if you are optimistic, more optimistic today than 5 years ago, why? And not just because there's a lot more trials, but specifically what sorts of advances really excite you and think that you think have really moved the bar way forward?
I can start. I mean, I think really the past 5-10 years has really been an explosion in research and developments on inherited retinal diseases. I think one of the key points, the approval of Luxturna, the first gene therapy in any human genetic disease, and that's an inherited eye disease. That's really been the key finding, a key change. So because just after that approval, we see that more and more companies focusing research on studies. So money and research is really critical to drive research forward. So another big development is stem cell based treatments. Creating stem cells from older tissue that was first done in 2006, 2007 or so. And after that, we know that we can take cells from skin, for example, or other tissues and make them into stem cell based and make them into stem cells, and you can make those cells into photoreceptor cells or supporting pigment epithelium cells. And those two are kind of really key issues, both gene therapy and stem cell based therapy. We have a lot of smaller compounds too that may be working as well. So the M-acetylcysteamide, maybe that's gonna work really well. There's one other drug. There's a few other drugs that can make, especially if you have stop codon mutations in the gene, so the system kind of bypasses that spelling error and reads it as normal. That's one really interesting area of research. Allele-specific oligonucleotides. That's also that may also be a way where you get a treatment every 3 months, and kind of trick the machinery and reading the gene as normal. So these are just examples of exciting new areas of research in the past 5-10 years or so. I think it's really a change. Yeah.
That's right. And toward that end, exactly along those lines, with the development of CRISPR-Cas9 being able to edit genes in post-mitotic cells, so cells like photoreceptors that don't divide anymore have their DNA, and if they have a mutation, there has not previously, prior to 5 years ago, been a way to change that mutation. If it was there, it was there. And if it was a mutation that prevented a gene from being expressed, you could maybe deliver a copy of the gene to try and replace it. And that's what was done successfully with RPE65, which led to a tremendous amount of interest in developing new therapies. That's one big sea change. But for large genes that don't fit into that carrier that they used for RPE65, that newer approaches, or for genes that create a protein that causes problems. So autosomal dominant diseases and sometimes will create a protein that you have to remove to be able to eliminate the harmful effects on the photoreceptors. And so both of those were diseases that we didn't really have a good solution for prior to 5 years ago. But there is a lot of potential for treating those kinds of diseases with either oligonucleotides that skip over parts of the DNA where the mutation is, or CRISPR editing genes that have mutations such that they can actually change the mutation and kind of fix it so that the photoreceptor expresses a normal copy of the gene or makes normal protein. Both of those being the goal have really changed the field. And finally, I think a number of the Usher syndrome genes are large, and so new ways of delivering genes to cells are really gaining a lot of interest in the field, and whether that be using 2 different vectors to deliver parts of the gene, or delivering a smaller bit of the gene that might be sufficient to create protein without delivering the whole large gene, or developing just novel ways of getting DNA into cells. Those are all areas of research that I think are really evolving and hold a lot of potential. And I'm certainly more optimistic every day, because I think there's a tremendous amount of research going on in this field. You said not just because there's a lot of clinical trials. Well, the reason there's a lot of clinical trials is there's a lot of potential treatments that have gotten through the proof of concept phase to the point that we're able to feel confident that at least there's a good rationale for putting it into a person, which is tremendous in terms of just, I think, giving me a lot of optimism that there will be therapies in the not too distant future.
And one thing I also think is exciting is the genetic testing. So 5 years ago,
absolutely,
genetic testing wasn't as good and as available. And now, especially with the program, the My Retina Tracker program, the Foundation Fighting Blindness sponsors, testing at Blueprint Genetics is really amazing. We can test pretty much everyone who wants to have testing, who has a genetic eye disease. And in the past, it was really hard to find a good way. It was very expensive for the individual person. And now, when we're equipped with the gene that's causing the disease, then you can go to the next step and you can look at what trials that may be available. So I think the availability and the accuracy of genetic testing has also improved significantly just in the past 5 years.
We owe Joan Fisher a huge debt of gratitude for all her work to make My Retina Tracker the big success that it is, as well as Brian Mansfield. So many thanks to both you, Joan, as well as Brian.
Thank you. I think it looks like we've come to the end of our session, and I think this is a really good way to end the session with excitement and optimism, which I personally have a lot of right now after being involved with the foundation for many years. So thank you to all of our panelists and all of our session attendees for your wonderful questions. If your question was not addressed, or if you have any additional questions, please email info, @fightingblindness.org. Thank you again, and this concludes our session.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.